concerns or questions. In the recent days, there has been changes in the media, or there has been discussion in the media about N95 and the aerosolized nature of COVID, and that definitely creates certain level of anxiety or concern in many people. I want to reassure the group that the evidence remain consistent. Vaccine clinics are not high-risk scenario. Aerosolized procedures, whether it's dental procedures or intubation in OR or ER, those are different level of risk, and N95 is recommended there. Vaccine clinics have many layers of protection. One of them is the screening at the front. So off the bat, we're not dealing with sick people. We know that. And the interaction with any person who goes through the hub for any particular worker is less than a couple minutes, far from the 15-minute window of time required for exposure to consider the risk sufficient to ask the person to isolate. You have the hand cleaning, the hand sanitizer, you have the spacing of every interaction. We have expert in IPAC, infection control protocols, and those clinics by no means require N95. I just wanted to address this just because it's a repeated question that I received from many staff and from many volunteers and a couple of staff. And again, this is an opportunity to thank you for everything you've done and to open the floor for discussion, for questions, including the trajectory of the pandemic and what might be coming forward or facing us down the road. There is a chat box if people are more comfortable writing a question there as well.
One question in the chat box. We have been able to purchase some N95s. Will we be allowed to use them?
Yes, most definitely. And if people feel anxious enough about it, we can provide N95. We manage the risk, but we also manage the perception of risk. So yes, please, if somebody want to bring their N95, by all means. There are certain risks with N95 though, just because it's too bulky, and if it is being used well, it has to be pushing against the face at all times. So from the use of it in the OR or dentistry, most people don't use it more than 1 hour. It's just not tolerable. So if a person is tolerating it longer, there could be the chance of anytime you touch it or adjust it, there is increased risk of touching your face, which is increased risk of transmission of COVID. Just for knowledge there, that people who want to use it, they're actually very well increasing the risk from certain angle. I wonder, Dr. Zayed, if you want to provide your part of the evidence, if need be.
Yes, good morning, everyone. I just want to add something that is very important, which is the hierarchy of control. If we look at, I would like to share my screen. I don't know if it's possible here, but anyway, for the hierarchy of control, it is important to know that it's like an inverted pyramid, with more effective at the base of the pyramid and the least effective is the apex of the pyramid, which is an inverted pyramid. The most effective things is elimination, which is the isolation, substitution, if there is someone is sick, for example, they don't come to the vaccine clinic. In the same time, we do the screening for the clients who are coming. Engineering control, which is the ventilation, the physical barriers, administrative control, which is working from like a staggering schedule and hand hygiene, and then the PPE, which is including mask, respirators, and gloves. And it doesn't include only the mask; it includes again the face shield and the gowns and goggles. So there is a lot of protection here. And if we suppose that someone is positive in the hub, say I am doing a case contact management, and I heard about a person who tested positive, who was asymptomatic and tested positive. By any chance, it can happen anywhere. When I do the case management of this situation, I will consider that either no contact or low risk contact, which meaning self-monitoring. No contact meaning 2 people who have been wearing masks and or full PPE, and in the same time it's less than 15 minutes encounter. So this is considered in that exposure. In that sense, it is a no contact. So it is really a safe environment. I had a lengthy discussion as the IPAC hub lead with Public Health Ontario, and they confirmed many times in our discussion that the vaccine clinic is not a high risk environment. N95 use is only used for in aerosol generating procedure, because as Dr. Ara mentioned, it is not really a practical mask to be used for a long time. First, it's annoying to be worn. In the same time, it can get easily wet, and you need to change it. It's not. It is what we have discussed and decided that it is used mainly for fitness, not as a filter in the context of an area with a very low risk. So someone, for example, wear the medical mask, but it's not really as fitting. So in that case, they can use it as a fitness procedure or a device, not as because they're filtered. So this is just, I want to make this very, very clear to you. And we have really gone through this discussion, a thorough discussion with all IPAC leads and Public Health Ontario, and all the infectious disease specialists in all our area in the West.
Ian, I wonder if you can share the screen for hierarchy and control. I put it in the chat. I don't think as participation, I cannot share my screen.
Yeah, just give me 1 sec, I'll pull it up.
I actually have that, and also the exposure if 2 person like wearing a mask. I have this table, but it's not easy to, yeah.
This one, Dr. Zaid?
Yes, there is one for the specific for COVID, but again, this can work. So as you see, as I mentioned, this is the inverted pyramid. This is the most effective in terms of protection, and this is the least effective. You can see that PPE is in the apex of the pyramid as the least effective measure, while elimination, which is if we translate the elimination, meaning screening people who are sick, who cannot come to the clinic, and we always tell to our clients also, you cannot get the vaccine when you are sick. Like, this is a known information to everyone. Substitution is someone who is, for example, where the employee who are working, we can replace the hazard by, if someone is sick, we can substitute by another person. Engineering control, which is ventilation and spacing. It changes the way people work here. As in the hub, we change the way we work so that we have an encounter of less than, like, it's really a very small time, definitely less than 15 minutes per encounter. So according to the case contact management, when there are a person who is positive, and then we ask the history, how long is the duration of contact? If it's less than 15 minutes, we consider that low risk. If both persons are fully PPE'd, this is a no contact. Like as a color-coded situation, we consider that green, not even yellow. And of course, the PPE, you are not wearing only PPE. It's like, it's not only the mask. So it is full PPE, like the face shield, the mask, and gown and gloves. So, and you change the mask every time. And typically and practically, if I am working in the hub, I would never use N95 mask. I'm talking about myself. I will always use the I will always use the medical or surgical mask.
Thanks very much. It looks like Mary McDonald has a question. She has her hand up. So Mary, if you want to ask your question, go ahead. Sorry, you're just on mute right now, Mary.
Can you unmute her?
There you go, Mary. We still can't hear you there, Mary. I don't know what. We can't hear you, sorry. Are you able to type by any chance, or are you on your phone? Okay. Sorry, Mary, we're just not able to hear you.
There's another point there until Mary gets through. From that hierarchy of control, there is a concept called risk perception, and risk perception and risk compensation. Those are two concepts that we live through, all of us. One example is winter tires. A person's driving in their vehicle and it's not winter tire. They are usually slower, they're careful, they're driving 60 kilometers an hour. They put the winter tires on and immediately they feel safer, and they drive a bit more, less careful, I would say. Their speed goes up. Similarly, you can see from this hierarchy of control, if somebody has PPE and they feel they are safer, which is, again, there's a risk perception here because the N95 is not going to provide more safety in this case. And I will explain why it would not. They might forego the other measures. They might get closer in their interaction with the other person. They might speak with them a bit longer. They might feel less inclined to wash their hands, all these things. So risk compensation, again, is a real factor in the equation. The N95, I don't believe we mentioned this so far, is a mask that requires fitting. So a person would go through an exercise, usually 20 minutes to an hour, where the mask will be put on the face, and the standard mask, then the pressure of air is measured. So there is a measurement to see if what kind of mask actually fits the specific face, and this face structure, it changes. So fitting needs to be done for each person within, I believe, two years. So if you have not done all these measurements, putting the N95 on the face is as good as the surgical mask. But because of all the bulkiness of it, the pressure of it, touching the face quite often to adjust it, that really does not introduce safety, it introduces the opposite of it. But not sure if Mary had her question now.
I don't hear Mary, so I don't believe she was able to get her audio to work.
Okay. Mary, if you email down the road, we can connect one-on-one if you wish as well.
Looks like we have another question. This was from Barbara Dobreen. I volunteered for a clinic on Friday. While N95s were offered, I opted for the medical mask and visor, as 4 hours seemed long enough to wear, a long time to wear an N95 mask. Dr. Zayed may have answered this concern, but double vaccinated individuals can be infected, but asymptomatic. While those who were only for 15 to 20 minutes a volunteer could be infected without knowing it, asymptomatic, and is there for a longer time frame. Is this still a low risk environment?
Yes, it is, because it's not only about the timing, it's also about, as I mentioned, that both persons are fully PPE'd. And fully PPE'd means someone is trained to wear the mask, wearing the mask and have the mask, the face shield, and gowns and gloves, and of course the hand sanitation. So it's still a low risk. So if we can go from, if it's more than 15 minutes, it will be from more than 15 minutes. In that case, I would say it's from green to yellow if we color coded it. And again, it is some self-monitoring, and it is also unlikely to get infected, very, very unlikely to get infected. Like I would say you would be infected in a mall or a grocery store more than in this environment.
Yeah, if I may add a bit more, I agree with that statement. You step back and look at the data. We have over 3,000-4,000 cases in Grey Bruce. How many of them happened in a vaccination location or in a pharmacy where a vaccine is given? Which is again, the hub is way more controlled than any other location there is. None, literally. You look at how many person got tested for COVID and tested positive, the number is 4,000. They got tested through assessment centers. In the assessment centers, the physicians and nurses are not wearing N95. Some people wear N95, but in general, it has been surgical mask. So, you know, if COVID is aerosolized all the time, every person who worked in an assessment center would be sick. If you look back at the data from different angle, how many of the 4,000 got infected in their home through family and friends? The absolute majority. How many in school, in a class? Around 12. That's a school. That's an environment where there is no N95. That's an environment where there are kids and there's interaction, and there are people who might be coming to school even if they're sick. And those were the cases happened. In the hub, on the other hand, like it is completely controlled. So the chances of a person, one of us, being sick or acquiring the virus at our homes is around 3,000 out of 4,000. That's very high. The chances of us getting it in school is 12 out of 4,000. The chances in the hub is 0 out of 4,000. Absolutely, I feel safer in the hub than my own home. I said it many times, whether it's related to school or the hub itself. And again, I do believe the media puts out many pieces of information. Like if you have the notion that ostriches are flying and falling on people, yes, there are a couple that are transferred by airplane, but we know they don't fly and they don't fall on people. And we can be very anxious about it because we saw it on the media many times, but we go to basics. COVID is part of the corona family. The structure of the virus, unless you put pressure on it, pressure with air, whether in a dentist office or intubation, it's not going to turn into aerosols. So again, I hope that really addresses it from multiple points of view. Any question in general about the hub or about COVID, Omicron, where we're heading?
Look at all the people that are volunteers, a lot. Huh?
Good morning, Ian. It's Maureen Selecki. I feel badly here that I'm in your staff meeting. I couldn't tell from the email that there was a difference between the two sessions. I think this has been helpful this morning, and I think it's a volunteer, but also as somebody who was in the healthcare system. I think people are going to need to have what you just said reinforced, that if they're now understanding, I think the general public is understanding that there is more aerosolization of this virus. They don't understand that it's under pressure, that you're more likely to be exposed. So I think that's an important message to reinforce with folks. Also, just say, having worked at the Chesley Clinic on Wednesday and having that delightful drive back from Chesley in the evening, there were lots of folks coming into the clinic whose masks were half off. And I think that's a problem. I would reinforce with the screeners. Usually I navigate, but I'd reinforce with the screeners that they should absolutely feel comfortable to tell people to have their masks up and over their noses, because that's not helpful. I think sometimes the volunteers maybe feel a little reluctant to engage in that conversation with somebody, but I think that would be helpful for folks. And just making sure people are clear about that surgical mask being on and being secured. I think some people feel better when they've got two on. Probably it doesn't make a difference, but I think they feel better. So it's really just to reassure folks, because I think people are very aware that there may be folks at the clinic through who are honestly reporting on their status when screened, but in fact are positive and will walk through the clinic positive and develop symptoms in the days to follow. So I think it's that reassurance that people need. And again, apologies for being in on your staff meeting, but that's just a perspective from having volunteered at a number of clinics. So.
Thank you, Maureen. Really appreciate this feedback, and no worries whatsoever. You're welcome at any time in any meeting. Everything we do in public health is public. I was actually in my training, I was given this analogy that anytime you're working in public health, just imagine there is a camera over your shoulder connected to Fox News and CNN. So no issue whatsoever there. And I really appreciate that feedback about the pointing out or flagging lax use of masks. We will definitely take it into perspective, put it in a process, whether it's the screeners at the door or the navigators or the volunteers themselves. We can put up signs to empower the volunteers to address this with anybody and everybody. Again, it's health for all of us and safety for all of us. And I usually start with that statement, but we went directly into the details. We take the safety of our staff and volunteers very, very seriously. Like, there is no question there if N95 is helpful or any measure is helpful. We're not going to spare any effort or expense to make it happen. And N95, there are hundreds of thousands of them. It's not like we're short of that. Bruce Power, as you know, provided 2.5 million, I believe, or 2 million masks. And right now there's over 100,000 N95 ready to deploy to, if need be. But again, the level of control and the safety of the hub is something we take very seriously, and that is already ensured with the measures in place. Tim?
Just as a follow-up to that, I worked in the clinic in Walkerton on Thursday, which was run by the Ray Lux and his staff of medical technicians. And I was wondering, how is your staff hanging in there? Have you had any sickness within your own group of employees or any issues with burnout? We see all this stuff on TV right now, especially in Toronto, about their ambulances and how many are not available because of problems with their staff. How is your staff?
So a good question is something we prepared for even before the pandemic. Pandemic management happens in a cycle, and the response part of it is the narrow part. Planning for it is always the major work. So before the pandemic, during the pandemic, and in mid-December, when we knew that Omicron is going to hit, we factored in if we are going to have 10 or 15 or 20% of our staff ill because they are part of the community. They have kids who are sick, whether it's COVID or not. Can we manage and ensure there is enough allocation of staff to the hubs? And we planned on different scenarios, whether it's for case and contact tracing, that's a function that's essential, or for vaccines, which is very important, but at the end of the day, we don't want to leave cases not managed. And there is enough capacity to ensure that is the case. If we really need to, if we got to a spot where many people are ill, we have the ability to have rapid testing for staff and volunteers to rule out COVID. If somebody, for example, had the sniffles for a few days and they recovered, well, we're going to ask them to stay home for 10 days. But if that's the only option is to bring somebody who was exposed or who recovered, we have the ability to test them beforehand, before coming into the hub. But at this point, there's no pressure to go to that measure, to that extent of measure.
Thank you.
We also do have one question in the chat box. What are the public health units PPE requirements for people working, such as front-facing cashiers? What are possible exclusions from requirements?
So just if I'm understanding the question, the PPE for just front desk in regular business.
That's what I'm reading in the question.
It is in general a mask, whether a surgical mask or regular mask or face covering. At the end of the day, from that, like, again, let me just share it. I realize that everybody saw it at this point, but those measures, we don't use one or the other, we use all of them. So physical distancing, the 2 meters is king here. Elimination, screening, and physical distancing, those are the gold standard there. So you can be 2 meters or more from a person without a mask for a period of time, and I would feel way more comfortable than wearing a mask and being very close to them. So again, you have all these measures in place, and at some point one of them might not be there, but you have the other layers of protection. And in general, in Grey Bruce, workplace has been very compliant, and wherever there is no compliance, there has been either complaints from the workers in that workplace itself or from the public. So we have been in this for over, how long have we had the mask? Maybe 16 months. People know exactly what they needed to do. I would not feel less comfortable in a workplace as well, comparing to schools, and definitely comparing to the hub.
Thanks so much. We do have Christina did ask a question in the chat box. In your opinion, Dr. Era, at what point do you think our province controls and closures, etc., are we likely to see a slowdown on Omicron? And when will we peak, or is it still unknown at this time?
In my own bias, with this level of transmission of Omicron, it will be a shorter period of time comparing to the Delta, for example. I'm thinking 2-3 months. But again, this is a very bold projection. There's always a surprise in these pandemics. They are very humbling. The Delta was, for example, a complete surprise on many fronts because it's more transmissible, which is understandable in pandemics. That's what happened. But it was also more severe, which is not the norm. Any mutation in a virus is going to result in viruses that are more severe or less severe, but natural selection is going to take out the ones that are severe. And Omicron did us a huge favor. It cleaned up COVID Delta. Delta would have been with us for a longer period of time with severe disease, and Omicron really cleared that. So again, with the doubling time of less than 2 days, many people will be infected, and hopefully the majority, the absolute majority, being realistic, some people are not vaccinated and might end up with severe disease, but the absolute majority will be recovered. And you look at time frame 2 to 3 months, this activity might be done then, or at least turned into an endemic, which is at the end of the day common cold. COVID-19 is part of the corona family, and corona family to humans is known as common cold, because at the end of the day, the virus becomes less severe until it becomes every 2 years, you get infected, you lose the immunity, then you get infected again, then you have immunity for 2 years, and so on and so forth.
And again, I just want to add that hospitalization is still seen mostly among unvaccinated. So vaccine, of course, is helping to reduce the severity. And as Dr. Ara mentioned, unless we will see another mutation, hopefully not, I think this will give, like with this high transmission of 1.6 day, this will help also to have this kind of herd immunity, in addition to the vaccine, of course.
And sorry, Christina, I'm just reading the question again. The slowing down of the control measures were slowed down Omicron. We are already slowing down. This is what's slowing down. How long this wave or how long will it take for people to get immunity from the vaccine or from the wild virus? Obviously, that's my answer there. 2 to 3 months. Most people would have been exposed to one or the other.
This might sound a little bit strange, but thank you, Dr. Ara, for that response. So are we thinking that it's better to actually acquire the Omicron and hopefully cross our fingers we're not one of those people that has complications, much like a chickenpox party? Like I'm getting confused because, we want to get it, but we're afraid to get it. And I'm going to protect myself not to get it. But it sounds like everybody is eventually going to get it. I'm still going to wear my mask, even probably as we eventually will let go of that particular control. But I guess my understanding of this is the wild virus that is supposed to help us get out of this pandemic. Is it better for us to get exposed to this? And obviously have your vaccination, because that's the key. I did see the statistics that would suggest that the hospitalization and the ICUs are decreasing, but are still high for those that are not completely vaccinated. So I guess I'm a little bit confused about that part. And yeah, I don't know if you can answer that.
No, sorry if I confused you. I would never suggest to have a party to acquire the wild infection. Our goal is to slow it down to prevent transmission. Can a person be careful enough not to acquire it? And when there is enough immunity in the community is not going to circulate and a person would not acquire it? Yes, there is. I'm not saying yet, everybody has to get it for us to finish this. Absolutely not. And then I'm sorry if my words even got close to that. The goal of the management of the pandemic right now is not containment, because it's not containable. Doubling time of 2 days cannot be contained, as simple as that. Our goal is to slow it down through vaccine, through all the measures that we have, through being extremely vigilant. And whatever the circulation of the virus, whether it's because of the winter or because of the transmission let people acquire immunity from the wild virus for people who were not vaccinated. Whatever leads to less transmission, at that point, if a person was careful enough not to acquire the virus, they're not going to acquire it at that time. But anyways, we are not there at this point, and I would not suggest a party whatsoever.
There's another question in the chat box. Thank you, Dr. Era, for your ongoing updates. You mentioned 75% of current cases were acquired in close contact, no PPE environment, such as in the home or perhaps parties, and only 12 cases in 4,000 were transmitted through the school. How many cases have been acquired from retail, restaurants, or personal service settings? I'm asking to understand why our small businesses are once again being restricted if all safety and PPE protocols are being followed.
Yeah, so let me just add a bit more to that. Probably more than 75% at home and friends. At different junctures, these numbers, are measured because we needed to send certain messaging to the public. But that's a rough estimate. The total would be around 75%. The 12 cases within class, there has been around 26 of the last time I saw that number a few weeks ago or a week ago, 26 related to school sports. And school sports could be related to school environment or could be outside of the school, because most of these players are buddies. They spend time together. I don't have the number off the cuff for the businesses and the restaurants, but the number of outbreaks in workplaces in Grey Bruce has been minimal. At any juncture, we had 1 or 2 in the waves, or maybe 5 or 6, but it wasn't, the outbreaks that we've heard of in other health units, 500 people sick or so. Why are they restricted? This is a question, like if you ask me right now, if Grey Bruce was an island, would we put the same measures, a lockdown? Probably not. If Ontario had the same level of compliance of Grey Bruce, the recommendation to the province from every MOH would be, don't put measures in place, don't lock down. But we are not living in an island, and any direction provincially will have to affect the whole province. And you can appreciate the opposite. Let's say there are restrictions across the province except for Grey Bruce. We turn ourselves into a magnet, because everybody who want a haircut will come from Simcoe, Muskoka, Huron, Perth, even Peel to Grey Bruce, because it's open, and we bring all the potential risk of transmission here with people who might be coming from these hotspots. So again, there is better practice in having provincial approach to those issues.
All right, one more question from Mary. Are you still doing contact tracing on all cases in Grey Bruce?
We are still calling every single case that we know of. We usually call them to let them know that they're a case and they need to isolate and their family. And on top of that, we do a risk assessment of their friends and close contacts and the whole spectrum. since we were directed by the province about 10 days ago to only focus on contact tracing in long-term care, hospitals, and first responders. Since that date, we continued to call people to let them know their cases. Then we would refer them to electronic management, whether it is the provincial task force or the notification through text messaging and online. So there are different types of management, but the baseline to actually call every single case is still there.
And to follow up to that, has the exposure time of 15 minutes been revised during Omicron as opposed to Delta because of increased transmissibility?
Dr. Zaid, can I refer this question to you? Like, to me, the 15 minutes is a fluid to start with. 15 minutes with somebody who's very careful, or 20 minutes with somebody who's careful, a paramedic, for example, is different from 5 minutes of somebody who's not, because it's one part of a risk assessment of many points in a checklist. It's never on its own, but to my knowledge, I don't believe it was changed. Dr. Zaid?
No, it hasn't been changed, but in the same time, as this is a multifactorial, the exposure is itself, you have to, for risk assessment, you have to assess agent, host, and environment. So if the agent here is Omicron, is more transmissible, there is a host who is not masked or is symptomatic, or the distance between the two persons is closer than 6 feet, and the environment is the environment ventilated or not. If it is if they have been sharing food or drinks rather than just or talking or singing, the activity in this environment. So many factors are together, including so the timing is itself is a fluid, as Dr. Era mentioned, but there are other factors that we are putting in consideration together to get this total risk assessment.
Perfect. And one more question from Mary is, how many incidental cases have we found in hospitals in Grey Bruce? I'm not sure if that requires clarification or not.
Yeah, the word incidental, I'm not sure what it means. I can answer. There are two types.
That people may be coming for another reason and then they incidentally had COVID. Is that what you mean?
Yeah, we don't count those, Mary. At some point, the hospital would report to us how many cases are hospitalized. And we had asked the chief MOH, and the chief MOH's office sent to all hospitals an algorithm to say if somebody got to the hospital with a broken leg and they tested positive, are they a COVID hospitalized case? And the answer is no. There was a change in the numbers very recently, but anytime we receive reports from our hospitals, we verify that point. Not sure if I answered the question, Mary, or there is still some angle to it.
She did have another follow-up there. Does that result in underreported cases?
It doesn't, because so in the hospital, there are 3 types of cases. One, people hospitalized for that level of care, whether it's oxygen or ICU as COVID, and we report on it on the SIT report. Any other case similar to what you described as incidental will be captured under new cases, but they're not hospitalized. They're not requiring hospitalization. So we report on both. There is a third type of cases in hospitals, cases that acquired the virus within the hospital, and that will be part of an outbreak. Hospital outbreak at this point, there is today, currently there is one in Grey Bruce, and it's a very limited outbreak, minimal number. The number of outbreaks in hospitals has been a handful, I believe, if my memory is right, since the pandemic started, and the number of cases involved in them has not been high.
Perfect. And it looks like Barbara has a question, follow-up to Mary's question. Of cases of COVID reported in hospitals on our daily situation report are directly related to be treated for COVID and not related for being hospitalized for another reason and positive for COVID. Is that correct?
That is correct today. There was about a week ago some correction where the hospitals were directed to report on all cases and they over-reported, but that was maybe a day or two in the data. Today, it's exactly like you described. Only people hospitalized for seeking care for COVID. And we looked at, before that algorithm came from the Chief MOH's office, we looked at local solutions to look at some proxies. And one of them is if they're receiving antiviral treatment. So unless somebody's sick with COVID and seeking care for COVID, usually they don't give them antiviral treatment. Anyways, we didn't have to use that a proxy measure to collect data, and the data reported by the hospital is based on the need for treatment for COVID.
Not seeing any new questions come in. I don't know, Dr. Ara, Dr. Zayed, if you want to have any closing comments for the group, and we'll go from there.
Yeah, from me, I just want to thank everybody. It really is in many ways surreal. Like, we've been living this for 22 months and it has ups and downs, and the only constant there that we have been able to depend on is the commitment from staff and volunteers. I cannot thank you enough for that. Thank you.
I just also want to echo that and really appreciate and thank all the staff and volunteers for their great work. It is really the most important support that we can provide to our community at this time. And hopefully, like, we are really optimistic, cautiously optimistic that we will get through this in a short time.
Perfect. Thank you, everyone. And as we
sorry, Ian, if I may add, sorry, I was on mute. I just put my cell phone number in the chat box. Please don't hesitate if there's any concern or question at any time. Thank you so much. Thanks, Ian. Back to you.
Yeah, sure. Thank you, everyone, very much. As we started this meeting, I did start recording this, so we will make the link available to everyone. We will post this and make sure that the volunteers and staff have direct access to this meeting if they ever want to go back for any of this information that we did cover off. So again, thank you very much, everyone. And that does bring us to the conclusion of this meeting. And thank you again for your support, as mentioned already. Take care, everyone.